This is part B on knee rehabilitation. So this would be the second page, full page of your notes if you have the outline with you. First thing we're going to start talking about is how much easier this would be if you were a veterinarian. Just kidding. All right, moving on. All right, we'll talk about ACLs first. Anterior cruciate ligaments, usually the mechanism is a cutting or hyperextension motion. Signs and symptoms include a pop with typically swelling within 2 to 24 hours. The surgical options can be and typically are delayed for 2 to 4 weeks. Because they want the swelling to reduce and get as much range of motion back as possible. So pre-op rehab will include regaining full range of motion, or as much as possible, strength, and then minimizing edema as much as you can. This just makes post-op rehab go so much easier. There are a few different kinds of grafts that can be utilized when somebody has a replacement done of their ACL. The patella tendon graft or bone tendon bone graft is probably the gold standard. In the notes, I just put a reminder in here that the rehab is typically between 4 and 6 months. 4 is a little bit on the low end. Typically 6 months is what we're seeing orthopedic surgeons saying that they're comfortable with and letting athletes return to play. With this type of graft, they'll take a middle third of the patella tendon, they take a little bone plug off of the patella and off the tibial tuberosity, and then they have something to some bony attachment when they put the new ACL in that they can screw into the femur and then also into the tibia as the new ACL. That space in the patella tendon then is typically sutured together. Hamstring graft is another option. Parts of the semitendinosus and perhaps gracilis tendons are removed and combined, and they become the new ACL. I've seen more of these occurring in rehab. I'm not sure if I like these or not. It slows down our hamstring strengthening protocol, which I'm not real thrilled about, and you'll see why here in a minute. But they are becoming a little more popular than they were 10 years ago. An allograft is when they use a cadaver's ACL. It's definitely the least amount of rehab time. This picture shows, it looks pretty bad in this picture. I don't think I've ever seen one this bruised up. But they rehab fairly well. There's no donor site for the hamstrings or the patella tendon. I think if I wasn't going to return to athletics or a real high level of competition, I would look pretty seriously at having an allograft done if I'd torn my ACL. On your handout, it says treatment and rehab program progression. In general, there's two kind of theories. One is a delayed program, where the patient is in on weight bearing for 4 weeks. They're in 15 degrees of an extension lag lock for 4 weeks. There's no closed kinetic chain for 6 to 8 weeks, and they return to running at 5 months. This is very outdated. Almost no one does a delayed program anymore, but it has existed. So I just wanted you to be aware that it was out in the rehab world at one point. Most athletes now, most orthopedic surgeons use the accelerated program where they weight bear as tolerated. There's no range of motion restrictions. They get them going as soon as they can. And a return to sport in 5 to 6 months. Again, our orthopedic surgeons in the metro area are seeing that if they release an athlete prior to that 6-month time, they've had some re-injuries, some re-tears. They have not had any re-tears in athletes that have waited 6 months and have passed all their functional progression tests, such as the noise test that was done in lab. And then full range of motion, we'd like to see it in 1 week. That's probably pushing it. You just don't see that very often unless you have an allograft. But just a reminder that the graft is at risk for rupture the first 8 weeks until the bone graft attaches to the bone. And then never does the graft strength return to normal. So remember, they've had a surgery. It's not going to be completely normal. There's some points of interest, and some of these are on this PowerPoint here that I want to make you aware of, that are very important when you're working post-operative ACL patient. The first one is to get full extension back as soon as possible. And I would say you have about a 2-week window. If it takes them longer than that, it's really, really difficult to get knee extension back. So before the athlete or the patient goes into surgery, I like to be able to visit with them and tell them, if you can only do one exercise, it's going to be an exercise for passive range of motion for extension. It's very, very important. We want to get the quadriceps firing as soon as possible. We'll do that actually with what's called a co-contraction. So that's on your notes. I want you to write in, get quads firing as soon as possible with co-contractions within 24 hours. A co-contraction is when the knee is placed in about 20 degrees of flexion over a foam roller or a pillow. The patient contracts the hamstring first in order to decrease the amount of anterior tibial shear, and then they'll contract the quadriceps. Now, I know in class I asked what was the most important muscle to get back for an ACL, and most people thought the quadriceps, and I can see why you would think that. It's a muscle that quickly atrophies. However, the hamstrings are what protect the ACL graft. It's very, very important that we get the hamstrings to contract well. So we'll do co-contractions when they're first coming out of rehab. The inflammation around the knee doesn't seem to affect the hamstring contraction very much. However, it affects the quadriceps. So that's why I can see why people would think, well, the quadriceps are most important because they atrophy really quick, and they are important. But as far as protection and function of the ACL, the hamstrings would be more important. Use patella mobs early in the first week. You can mobilize superior, inferior, medial. Be careful on the lateral so as to not predispose them to a dislocation. They should be full weight bearing in about 2 weeks with minimal compensations, unless they've had a meniscus work done as well, and then that's going to be significantly longer. But if it's just it's a clean ACL repair, in 2 weeks we should be about full weight bearing. In 1 month or 3 to 4 weeks, you should expect 120 degrees of flexion. And that would be a passive or active assisted, that they can get their knee flexed to 120 degrees. Active full range of motion, certainly by 6 weeks post-op for both flexion and extension. On your notes, I have that a treadmill placed at a 12% grade will reduce ACL strains and increase quadricep strength. So you can start somebody when they can walk without pain and start putting them on a treadmill at a 12% grade. That may seem really high and kind of intense, but they're just doing a slow walk, not jogging by any means, but that 12% grade can reduce some of the shear force. Return to a running program may begin in about 8 weeks post-op. That's fairly common. They don't start going into full running, but it's they'll walk for 4 minutes, jog for a minute, and continue to do that for about a week to a week and a half, and then progress on so that after about a month, they're hopefully able to progress into 20 minutes of a straight jog. The hamstrings are very important. We talked a little bit about that with the co-contractions. The graft itself is the weakest between weeks about 8 to 14. So the graft, when it comes in, has a vascular, once they cut it out, there's no supply. But once the capillaries begin to die off, the graft actually becomes a little bit weaker until it starts to recapillarize, and so between 8 to 14 weeks post-op, we have to be really careful for those athletes that are highly motivated, that they just don't go crazy and feel like I've got full range of motion, I've got really good strength, I'm going to go out and start running agility drills or doing a lot of seated knee extensions. The graft is the weakest then, and we really have to protect them and do a lot of careful strengthening through that part of the program. Partial tears or full tears that don't undergo surgery usually will have a meniscus tear or an injury within a year. So if somebody says that they partially tore their ACL and they chose not to have surgery, you can probably expect that they're going to be in less than a year with a meniscus injury. They might develop patellofemoral pain or patella tendinitis if your program is too aggressive, especially with those that use that have had the bone tendon bone or patellar tendon graft. So you might have to slow down your rehab a little bit. I put in your notes Wilkes and Andrews and Sherborne and Nitz. These are the guys that have studied ACLs for years and years and years. And so if you do any research or start working a lot with ACLs, these are some of the names that you'll want to start to look up in literature. Isokinetics, if you've been asked to perform isokinetic testing on an athlete, you can do that. I probably wouldn't do that until they're about 4 months post-op, so about 16 weeks, and then make sure that you have the anti-shear device on so that they don't pull so hard with the quadriceps into open kinetic chain extension that they pull those bone plugs loose or even rupture the graft, which would, again, be pretty horrible. A reminder that the screw home mechanism takes place in the last 20 to 30 degrees of extension where the tibia rotates lateral. It's unlocked, so it goes back into internal rotation as the knee flexes by the popliteus. But the femoral condyles are kind of what help dictate that screw home mechanism. So you might have to do a little terminal end range extension mobilizations if they aren't getting full extension. And then I don't have this on your notes, but on the screen it says avoid open kinetic chain knee extension for the first several months. Again, this is because we want to protect the graft. We don't want some open kinetic chains would be somebody sitting on a knee extension machine or sitting on the end of a table and doing knee extensions against TheraBand with their foot is moving freely with the knee stabilized. Lots of anterior tibial shear stress taking place there, and we want to protect against that. Just a note before I go into PCLs that there are a lot of ACL protocols out and available, and I'll open up a protocol list actually on Moodle so you guys can get an idea of some of the protocols that are used in the orthopedic centers around here by surgeons that do this. They work really closely with physical therapists in developing these protocols, and so they're going to be on Moodle. You can feel free to get a hold of them if you want, which might help you in the future to kind of get somebody going on some of these post-op situations. But with those guidelines in mind that I just told you about, you should be able to easily run the first month of a post-op ACL. PCL injuries, it's a little bit longer for their rehab if they have surgery. Now, I've only seen one that's had a surgical repair and took about 9 months. The mechanism is typically they're hyperflexed, or they say also hyperextension, but the dashboard injury where they're flexed to 90 degrees, car accident, and their tibial tuberosity jams into the dashboard, driving it posteriorly while the femur is still driven anterior, and a tear of the PCL. Most patients, however, will recover without any sort of surgical reconstruction. The one that I saw was post-operative was because they were going in and repairing the ACL, the MCL, and they went ahead and repaired the PCL because they were already in there. This was also potential D1 gymnast, and she wanted anything done that could be done to give her more stability in that knee, but that was a little unusual. For PCLs, we have kind of the opposite muscles working here. We really want to work the quads. We'll work the quads a lot. We'll work them hard. We're really careful and avoid active hamstring and gastrocnemius. Contractions at greater than 30 degrees of knee flexion, again, because then we start to get a posterior tibial shear, and we don't want to have a lot of shear force going on, even if there's been no repair that might disrupt the meniscus. So avoid active hamstring and gastroc at greater than 30 degrees of knee flexion. Work the quads, and you'll work them hard. Strengthen them in a closed kinetic chain exercise, so they're in weight bearing as much as possible in order to decrease the tibial translation. And then the return to running is usually delayed somewhere between that 8 and 9 months post-op, if they've had surgery. So again, we just don't see a lot of these post-surgical, so their timeline is going to move up as far as what they can do, and it's dictated a lot by symptoms and function of how they progress. Just a reminder, again, one of the most important muscles to strengthen with the PCL is the quads, and with the ACL is the hamstrings. A tight second would be quadriceps, just because they atrophy so quickly after surgery. When we talk about collateral ligament sprains, return can be anywhere from 2 to 3 weeks up to 4 to 6 months, depending on what's done. The MCL injuries are more common than the LCL. The MCL injuries are rarely surgically repaired, and the responsibility is to teach the athlete how to strengthen the muscles that cross the joint on the side of the ligament injury. So things that cross the medial side of the joint, the adductors, the hamstrings, sartorius, the gastroc, anything that can provide stability to that as well. And then above and beyond that, you probably have to use some bracing if there's grade 2 and 3 MCL tears that's given the athlete some problems. Those are fairly straightforward, though, so once they get range of motion back and strengthen those muscles, just working them back into functional activities for their sport, and they return fairly well. The next set of injuries is meniscus injuries. They can take up to 3 months for repair. Just a few notes here that the MCL, medial collateral ligament, is attached to the medial meniscus. And with knee flexion, the menisci are pulled posterior by the semimembranosus and the popliteus. So with active contraction of the knee. With knee extension, the menisci are pulled anteriorly by the menisco-patello ligaments. So we have more of a passive anterior motion of the meniscus and an active posterior motion of the meniscus when it goes from extension into flexion. The meniscal posterior horns are primarily degenerative tears, and anterior and lateral horns are often traumatic tears. That doesn't mean that the posterior horn can't be traumatically torn, but if there is a degenerative tear in the menisci, it's usually in the posterior horn, which simply means the posterolateral portion of the meniscus. Surgical treatment for meniscal injuries might be arthroscopic if it's for a partial tear, or maybe they're just removing a segment that's torn off. They can do meniscus repair and just suture together the tears. There are allograft replacements, so they can take out a meniscus and repair it with an actual allograft. The width of the meniscus tears will sometimes dictate what's done. The ones that do really well with a repair, meaning they just suture up the tear, are those that are between about 2 to 6 millimeters in depth. And a meniscal repair is typically anywhere from 3 to 6 months of rehab versus a meniscectomy. And the meniscectomy is they actually go in and they remove the whole meniscus. They try to avoid doing that. The rehab is relatively shorter, so you're talking 1 to 1.5 months, but the long term is not good. You don't have anything to cushion between the tib and the femur, and then you're just more likely to get osteoarthritis or articular disruption of that joint. Isolated meniscus tears are typically degenerative versus those that accompany an ACL tear, and then they start to have an unstable knee. So you can have either one. Treatment and rehab program progressions. A conservative program is non-weight bearing for 6 to 8 weeks, and they're in a knee flexion bracing, so they aren't allowed to go into much flexion. Accelerated program, which again, if they have surgeon in the metro area, they're almost all going into the accelerated program where they're normal ambulation in 2 to 3 weeks. That is, there's an exception to that, so if they have that meniscus sutured together, that'll probably be a little bit longer. Range of motion and quad strength is the first priority with rehab, so get them going. Remember, they had the cushioning between two weight-bearing surfaces worked on. So you need to be a little bit tender and careful with weight-bearing exercises. So step-ups are not a great idea to do right away. Wall sits, leg press with heavier weights. Those aren't good things to have them do when they have to be in a weight-bearing position and then contract the muscles around that joint really hard and compress that joint together. So the first few weeks we're working on mainly range of motion, some non-weight-bearing exercises. Keep their cardiovascular fitness up, and then making sure that the opposite knee or side is also getting a workout. Here's a picture of the transplant I was talking about that are sometimes done. Moving on to patellofemoral injuries, and some of you will groan because these are typically chronic things. They're not easy to work with. It's long rehab, and the patient really has to be dedicated to the rehab. So a few notes to point out. First of all, that the greatest patella compression forces are from 60 to 90 degrees of flexion in closed kinetic chain. So go ahead and write that down, and we'll look at this slide. Greatest patella compression forces are from 60 to 90 degrees of flexion in closed kinetic chain, and the greatest patella compression forces are around 0 degrees of extension in open kinetic chain. So let's start with the closed kinetic chain. If we look at this graph here, the dark green lines are the closed kinetic chain, so you're in weight bearing, and we're looking at how much stress there is between the patella and the femur. So the closer you get into a squat position, so closer to 90 degrees, the more patellofemoral stress there is. That makes sense. It's just pushing that patella into the femoral intercondylar groove. So with somebody with patellofemoral joint stress, we would want to avoid going into deep flexion, okay, and standing. So they'll maybe do some mini knee bends, mini squats, some step sides on maybe a 2 or a 4 inch block, really low. Open kinetic chain, so non-weight bearing. If we look at compression forces of the patella at that point, the lowest is when we are at 0 degrees. So if you're sitting at the edge of a bench and you extend your leg, the patella compression forces are the most minimal, or they're they're the greatest, excuse me, at 0 degrees. So the closer we get to 90 degrees, so you can imagine somebody laying on a table and you're bending their knee up, we have decreased patella compression forces. So if somebody's in standing and they have patellofemoral pain, we're going to work on between that 0 and 30 degrees or 45 degrees of flexion. If they're sitting, we'll work them primarily between the 90 to 45 degree range, and don't let them go into terminal knee extension. Really important. So do closed kinetic chain from 0 to 30. Those would be like step up, step sides, steps downs. Do open kinetic chains from 90 degrees to 60 degrees, long arc quads, seated knee extension if you have to do those. We talked a little bit about patellar orientation. So I'm not going to really go over this. Actually, this slide is a little bit misplaced, so I think I'll skip over it. Well, maybe not. We're going to talk about Patellofemoral. The first section on your outline says talks about patella dislocations and subluxations, and they can take anywhere from a few weeks to 10 weeks. What do we do here with these people? They've subluxed probably laterally, ripped all the medial tissue and retinaculum. The older literature said that we need to provide patella control by emphasizing strengthening of the vastus medialis, especially the oblique fibers that come in. Subsequent studies have said that we can't isolate this muscle out, and really what we need to do is just strengthen the entire quadricep. So that's what we do. We do a lot of quadricep strengthening exercises, an open chain and closed chain, maybe assess from some orthotic needs. Might have to have a brace for some sports if they continue to dislocate. As we move on to number 2, the patellofemoral syndrome, there can be several underlying factors. It can be contributing tight IT band, gastric soleus, hamstrings, weakness or imbalance of the VMO, excessive pronation, an excessive Q angle, hyperextension, patellar alignment. So there can be several things that need to be looked at, although some tend to surface a little bit more than others, so I'll highlight that as we go through this. Patella orientation, we talked about this in class, that most often you'll see a lateral glide of the patella, so it's shifted over in that groove. You might have a lateral tilt as well. So the medial side is actually up, it's tilted towards the lateral side, and we need to tilt it back medially. Just a cross section here. Sometimes this is really blurry, it's not your own vision. We might have a view of this like on the MRI, and we want to see the space underneath the patella to be equal pretty much all the way through. So if we look at corrections that we can do stretching. So if we've got tight IT band, gastric soleus, hamstrings, those structures can be stretched. I'm not convinced that those are super effective, but they might be. Strengthening, we're going to talk specifically about strengthening later, but in general, I want you to start thinking of the glutes and the quadriceps. And then taping. So we talked about this in lab, the patellar taping, so I won't go over it in detail, but here's a picture if you forget of a lateral glide correction, the lateral tilt correction. We always tape for the most significant component first. Sometimes you might hear somebody say they've got a rotation of the patella. There are rotation corrections. We didn't cover that in class just because they're not as common. With the tape, the application, the athlete should wear that for 24 hours with 1 hour off during the day for 2 weeks or until the symptoms decrease, and then we begin to wean them off of the tape over time, so that hopefully in a month they aren't really even needing the tape. There might need to be some soft tissue mobility addressed, so some people claim that if you do a lot of stretching and massage to the iliotibial band and lateral retinaculum of the patella, that can really help. Additional therapeutic exercises might include assessing the lower limb alignment and biomechanics such as excessive pronation. They may say that, oh, they've got a compensated hindfoot varus and tend to overpronate, so we're looking at orthotics. Sometimes they'll complain of posterior tib or anterior tib pain associated with patellofemoral. What I'm really interested in and where rehab has gone lately is pelvic stability. And pelvic stability includes strengthening of the abdominals, the glute med, lots of core stabilization. The theory used to be that the patella was actually moving around on top of the femur, and that's not quite as common of a thought anymore. The thought now that is most prominent in rehab is that the femur is internally rotating and adducting out from underneath the patella. and that we need to control this motion at the hip. Oh, I guess I'll stay on this slide and not move on to the next one. But on your notes, under strengthening especially, quadriceps are still strengthened a lot as long as it's in a pain-free range of motion. Again, in weight bearing, that's going to, or in closed kinetic chain, that's going to be from that 0 to 30 degrees. So we might do some short arc quads, but actually in weight bearing, might do some quadriceps sets at different angles if they have a lot of pain. Mini squats from 0 to 40 degrees, leg press maybe from 0 to 60 degrees. So those are all good quadriceps strengthening exercises, step down, step side, and step ups, all of those. You'll still see some therapists and some facilities that emphasize adduction exercise to facilitate the VMO. There's really very little evidence to support that this is helpful. This came about because one of the nerves, or the nerve that innervates the adductors, one branch of it also innervates the VMO. So the thought was, if we can get the adductors to fire, then we can also get the VMO to give us a good response. And selectively strengthen that, but that's not true. They found that they cannot selectively strengthen the VMO, so again, do your quadriceps strengthening exercises. I don't know that I left you much space for this. Again, to make sure that you understand that the gluteus medius is really what needs to be strength. The glute max is what needs to be strength in order to abduct and externally rotate the femurs and get them better aligned underneath the patella. We'll talk about this a little bit more in the case study as we go into it. If people are really, really involved, I guess, and we don't get any symptom relief, and they've really been working hard in rehab. There is surgical corrections for this. They do what's called a lateral release, and they actually release the lateral structures that hold the patella to the lateral direction. They may even go so far as to realign the tibial tubercle. So they sounds horrible, but they remove the tibial tuberosity at where the patella tendon inserts. They take that whole structure and they'll move it medially and reattach it. So they've shifted the whole patella alignment structure medial. We used to see a fair amount of those in rehab. They were nightmares for rehab. I haven't seen one for years. I think that I would probably have that surgery done if I absolutely couldn't walk and I was short of total knee replacement in order to decrease the pain from Patellofemoral syndrome. It's a huge surgery. It's not that successful. And when you get a patient that's had that done, you're in for the long haul. It just takes an immense amount of rehab. Moving on to patellar tendinitis. We're going to use modalities and cross-friction massage, maybe patella brace or patella taping. That's what we reviewed today in class, was the patellar taping. Oftentimes stretches for the hamstrings, quadriceps, and calf are recommended. Again, I'm not so convinced that those make a significant difference. Strengthening the quadricep is where we found the best results. And the best results, I know I have in the notes, it says in open kinetic and closed kinetic chain, starting with concentrics and progressing to eccentrics. What I would say is what I have written on this slide is the decline step down. So somebody does a step down on a decline board at about a 25% grade, 3 sets of 15. And they do the concentric with both legs, and they go down into the decentric, or the eccentric on the decline with just the one leg. So if I have patellar tendinitis on my right side, I'm going to be standing on a decline ramp that's at about a 25 degree angle, and my toes are going to be lower than my feet. So I'm not doing a gastroc stretch. I'm flipped around the other direction like I'm facing downhill. And I'm going to bend both knees going I'm just going to bend one leg going into an eccentric on the involved side, and then I'm going to either shift my weight to the other side and do the concentric, or I can just put the other leg down and help with the concentric. For 3 sets of 15, I'll go as low as I can until it becomes a little uncomfortable. I do this every day, and when they become easy, I start loading weight into my hands, dumbbells, a weighted vest, whatever, but I want to keep increasing resistance as much as possible. So that's really the standard patellar tendinitis, or actually tendinopathy, rehab that we're doing now. These pictures are a little out of order. They should have been earlier for Patella Dislocation. So just a reminder, you think of how many of the medial structures have to tear for this patella to be dislocated. And that patella should not be there on the side of his thigh. It should be up on the top. So some of you have heard the term grasshopper patella, or frog eyes. There you go. He's got a frog eye. Moving on to Osgood-Schlatters disease. We have an excessive tenderness and probably visibility of the tibial tuberosity as the patellar tendon comes in to attach to the proximal tibia. The person is usually skeletally immature, and they're doing a lot of quadricep activity, so they're doing a process actually of a slow chronic avulsion of the tibial tuberosity right off of the tibia. Now it's not going to come off, but it becomes so irritated and painful that they don't want to jump or weight bear on that. So what do we do with these athletes that are usually in that 15 to 19-year-old range, typically boys? Lots of modalities, whatever works to decrease pain, stretching of the hamstrings so that at rest the knee doesn't really want to go towards flexion. The comfortable resting position is extended so the quads don't pull on that. It's recommended to do IT band and gastroc stretching, a strengthening of the quadriceps in a pain tolerable way. So it might be just starting with quadriceps sets, and can they even do that? And then cross friction to the patella tendon. If this has been a chronic problem going on for over a month, then we might do some cross friction. So actually usually self-resolving. I mean, you could do nothing to them and they'd probably get better, but people don't want to wait that long, or parents want to bring their son in and they want to get the magic pill so they can get better quicker. Sometimes they'll get quick, sometimes it doesn't, but you can certainly reduce their symptoms. Plica syndrome. So when we're going through developmental process in utero, and our knees are forming, and they're forming this capsule around the knee, it comes together and you have this last seam as the capsule forms together, and it's called the plica, and it's usually on this medial superior side of the knee. And that can actually get fairly irritated and cause a lot of pain at the knee, and the symptoms almost look identical to a meniscus. In fact, I've heard stories of people going in and they thought that they were going to have a meniscus repair, and there was nothing wrong with their meniscus, and the surgeon saw this huge plica seam, and so they ended up removing it, and the person got a lot better. I've heard nightmare stories too. Well, probably not nightmare, but they thought it was a plica, and they went in and found that it was a torn ACL. So it can get kind of confusing, and usually the plica syndrome diagnosis is reserved till the very end when they really don't know what else could this be, and the pain is located into the medial superior portion of the knee. What we have found best, and what I find in the literature that is typically helpful, is making sure that there's not excessive tension on the quad, so stretching the quad, stretching the hamstring so that the knee can go easily into extension, and modalities for pain reduction, and that would include ice and or ultrasound. And surgery is done if the symptoms don't resolve, and the surgery is fairly successful. The rehab is easy. It's just return to range of motion and strength as they're able to, and it's not really that involved. Iliotibial band syndrome. I don't think that's next quite yet on, I skipped over strains and contusions. The thing that I want you to remember about hamstring and quadriceps strains is that you need to eventually eccentrically strengthen them. So I ask you about this on the exam. Make sure that you have a couple ideas on how to eccentrically strengthen the quadriceps and the hamstrings. Modalities can be used to decrease pain, increase flexibility through stretching. Remember, if it's the hamstring you're trying to stretch, then they need to have an anterior pelvic tilt. If it's the quadriceps that you're trying to stretch, you want a posterior pelvic tilt, and you need to make sure that that's instructed as well. So increasing strength with emphasis on the eccentrics are very important, as well as the stretching position. So iliotibial band syndrome, they typically come in with signs and symptoms complaining of lateral knee pain. So from about where this gal's fist is down to her knee, she might have complaints of symptoms there, or a little maybe posterolateral at the knee, so it can sometimes be confused with the posterior horn of the meniscus. The mechanism could be, it's similar to Patellofemoral. There could be a ton of things. It might be training issues, running down hills a lot, a leg length difference, increased Q angle, foot pronation, muscle imbalance proximally, so they've got weak hips, weak core. All that needs to be evaluated, and then you address what you see or what you find that's weak. So I guess you could say the overall plan is easy: stretch what's tight and strengthen what's weak, assess their posture, maybe do some pain relief types of things with modalities, maybe transverse friction massage or soft tissue massage. You may choose to use orthotics. These are treated really similar to Patellofemoral. You got to think core, and you got to think quadricep strengthening. So lots of glute meds, lots of glute max strengthening. And just to remind you of where the glute max sits, posterior. So if we go into hip extension, we have a lot of glute max movement. It does some external rotation, but not a lot. However, your glute med does abduction and external rotation when we're in an extended position. So start thinking about exercises that you can do to strengthen the gluteus maximus, and they should include hip extension of some kind, whether you're weight bearing or non-weight bearing. And then the glute medius. How can you strengthen the gluteus medius? That should include abduction of the hip and external rotation. So we're going to talk about those in class. Those are really important for patellofemoral and iliotibial band syndrome. The last one I have down here is osseous injuries. If it's a fracture, there's something called chondral resurfacing technique, where they can go in and try to resurface where they've had some disruption of the cartilage. There's also called microfractures, where they'll go in and drill little tiny fractures into the ends of the femoral condyles and actually kind of build up some bleeding in hopes to get the repair, and kind of fairly successful on that. They come into rehab and you treat what you see, so limited range of motion needs to get better and strength needs to get better, and the doc tells you how long you have to wait for that. Okay, back to Osteochondritis Dissecans. So with this, it's we've got a little bony chip you can see that's come off of the medial femoral condyle, and this is typically the place where it happens. They're not really sure why this happens. Some will say there's an acute injury that caused it to happen, and some will say no, it's not associated with an acute injury. My son had osteochondritis dissecans, not OCD, obsessive compulsive disorder. Some of you are going to be thinking OCD is, but in the rehab world, it's a physical therapy rehab. We're talking osteochondritis dissecans. Playing soccer indoors, fell on a bent knee and had pain after that. Had some swelling of the knee that didn't resolve. Took him in, showed on MRI that this bone was actually dying, so we have necrotic tissue, and the rehab was easy for me, or essentially easy, theoretically easy, because they're supposed to be non-weight bearing until that repairs, and then we just slowly start weight bearing through that surface. The hard part is when you got a 9-year-old kid that isn't supposed to be running, jumping, or stairs, and it's the middle of winter. So you get kind of creative, and you're really thankful for indoor pool facilities like the Shoreview Community Center. These just get better typically on their own, and if they don't, they're a surgical candidate, so they have to go in and decide if they're going to do a microfracture or put this piece back in. So, but you might see an Osteochondritis Dissecans patient, not very often though. I think that this wraps it up. So the last slide is an MRI of Osteochondritis Dissecans. I guess you can kind of see that black area in the middle, up on the femur. And I got really excited about OCD apparently when I put this together, and wanted to show you all sorts of pictures. A little overemphasis on this, sorry. So here's our case study. It's written on the back of your sheet, so just review it. I think that we'll probably do the same thing on Thursday. We'll meet in the athletic training room. I'll let you pull out a slip of paper so you know exactly what you're going to be doing, and instructing this athlete. So I'm going to get a little more specific though, so just know that when I say isotonic, so anyway, read the case study. If you get something like isotonics, I'm going to be asking you specifically if they should be closed chain or open chain, so understand the differences in patellofemoral joint compression forces for that type of thing. We'll see you in the training room on Thursday.